Hello and welcome back to the Advancing Healthcare Innovation Show. I'm your host, Michael Stamatinos. And if you're new to us, welcome. It's good to have you here. We're excited because we're having some just phenomenal conversations with real leaders that are painstakingly reshaping the future of health. And we're really passionate about a few different areas. We're passionate about innovation, access, leadership. And if it's your first time tuning in, let me just take a very quick step aside here and fill you in a little bit more about what we're trying to get done here. So, our focus is bringing real stories of innovation to life, highlighting leaders that are actually getting things done, not theory, real things, giving them the space to be able to share their stories with our community and ultimately with the world. We've got an amazing action-packed year. Wherever you are, we have incredible speakers. So however you're watching this, if you're consuming this, watching it, or listening to it, please hit the subscribe button now. Okay. So I'm really excited about this guest coming onto the show. In fact, it's going to be really good. It's going to be so good because we've done this now twice. So our guest today, she's going to hit you on a human level before this ever turns into a business conversation. So Michelle Zimmerman is the CEO and co-founder of Previvor Edge. And her work really kind of grows out of something that many of us kind of know really well. Family, uncertainty, sitting with someone that you love as they face cancer and trying to navigate, questions that feel bigger than you. Those moments shaped Michelle and they set something in motion. And then there's the professional side. Before founding Previvor Edge, Michelle helped build a cancer genetics program at Semaphore. And like what she saw there really changed everything. People with elevated risk and no clear path. Like a system full of talented experts, like who weren't working together. So patients left to kind of really piece everything together on her own. And that's something that she wasn't able to ignore. And hence Previvor Edge. So that was her response to all of that. And it brings internal medicine, genetics, oncology, and lifestyle medicine into one unified place. It helps people take action early. It brings clarity with everything that seems foggy, and it creates confidence, especially at a time where, usually fear takes over. So today we're going to explore a few different areas. We're going to explore the human side of prevention, the fear that people carry, the choices that they face, and how the system fails them, and what becomes possible when someone finally gives them a real roadmap. So, Michelle, it's great to see you again. Welcome to the show.
Great to be here. Thanks for having me.
Awesome. So, hey, so before we dig in, kind of want to start with you. When you think back to like childhood moments that kind of pushed you towards this work, like what is like a memory that's very apparent to you that kind of hits you the hardest?
Yeah, I think for me, I've always been motivated by solving problems that matter. And cancer is an easy one to be motivated by. On a
Yeah.
personal level, I have a very, very strong family history of cancer. Multiple great relatives, three great uncles who died of gastric cancer in their 50s. I have a close cousin who survived stage 4 pancreatic cancer. And a very, very, very close family member was recently diagnosed with cancer that was found early because she was in a high-risk screening protocol. And so on the
Mm,
personal side, I have seen cancer. And then, on the professional side, and this is where I'm going to take you back because I'm a person who likes to connect the dots.
yeah.
I started my American healthcare career because I'm originally from Toronto. When I was at Aetna, incubating and launching new companies for them over a decade ago. And this was in the era where people were focused on metabolic disease and they were focused on people not getting diabetes and they were focused on people not having a heart attack. And so
Mhm.
there's this world in which people are willing to invest in prevention activities in order to reduce the chances of an acute event. And so I saw that, and I saw that as a model. I saw that as a wellness model, and that was something insurance companies, employers cared a lot about. And then fast forward a decade, building the cancer genetics business at Semaphore, I saw that in cancer, all we do is talk about cancer. We never talk about what happens before cancer. We never talk about how you and I are sitting here virtually and we have very different risks of developing cancer. We should be
Yeah.
doing different things, and not just because I'm a woman and you're a man, because our risks are
Mhm.
fundamentally different. We should be screened different. Our lifestyle is different. Our medical history is different. And so I thought to myself, okay, well, cancer is an acute event. Like no one wants to be diagnosed with cancer. It is the number two cause of death and the most expensive chronic disease, if you want to give it that label. And the activities and investment that we are making before people get cancer is limited. There is no
Mm.
subspecialist responsible. And so when you marry together sort of like the experience with cancer with close relatives and friends, with this paradigm that exists in other chronic disease areas and very prevalent areas, right? You have the average person has a 40% chance of getting cancer. It's not a rare thing. Um, there is this major gap. Like we should be doing better. And I'll make one other point because this just happened last night. I was at a fundraiser for a nonprofit group in pancreatic cancer.
Hmm.
And they honored two individuals. One individual died from pancreatic cancer within 5 weeks, and the other
Wow.
individual survived pancreatic cancer. She was a previous breast cancer survivor, and
Hmm.
she survived it. She's been a survivor now for 5 years. And I thought to myself, I said, wow, and obviously, the focus is around showing that there is like both acknowledging the challenge of that specific disease, pancreatic cancer, and also acknowledging that people could live and the therapies are getting better. And I thought, well, what about the prevention? And what about the detection? And how many of those people knew they had a family history? And how many of those people had a BRCA mutation? And so there's just so much we can do. And I think it's time for the paradigm shift. Like we should do for cancer what we did for cardiovascular disease. We should do for cancer what we've done for diabetes. Um, and that
Well,
requires,
what gets in the way of that? What stops that? Is that policy? Is that how things are reimbursed? Like to talk about sort of maybe even the advocacy portion of that.
I mean, I think it's a multi-layered response, and I'm actually in the process of writing a blog, which is which is titled like, is the reason we don't do cancer prevention because we don't have a drug? Because if you think about cardiovascular disease, there's a couple of things about it that are interesting. One is we can very clearly identify somebody with an elevated risk because we could look at their cholesterol, we can look at their heart rate. They're like very clear signs, and it's sort of like black and white. The second thing is we have drugs, right? When someone's at elevated risk, we have drugs that we give people.
Yeah.
And so, there is like a very clear intervention that reduces your chances of an acute event. Very similar if you think about diabetes, we measure your sugar levels. We measure your A1C1. We can see when you're falling into diabetes. We can see when you're pre-diabetic. And we have
Hmm.
drugs. Yeah, we have even better drugs with GLP-1s. We have insulin. And in cancer, the first thing is cancer is 21 different cancers. Cancer is probably the most complex disease because it is because it's the mutations are all different, and some might say cancer is a whole bunch of rare diseases because cancer, you see one type of breast cancer, it's one type of breast cancer. What stage is it? What's the mutation? Is it
Right.
hormone receptors? It's very complicated. So I think one is how you stratify people for risk is hard because you have to look at family history, genetics, medical history, lifestyle,
Yeah.
environmental exposure.
Yep.
What you do to manage people on screening and risk reduction is also multifactorial. It looks at a different set of guidelines. It looks at the NCCN, not the Preventative Task Force guidelines. And then how you intervene is both screening and you need to screen for different cancers in different places, and risk reduction. Sometimes surgical, sometimes therapeutic, like low dose aspirin, and sometimes it's lifestyle related. And so I think it is multidisciplinary, and anything multidisciplinary in a healthcare system that is built on functional, single function expertise is
Yeah.
challenging. I think the second challenging thing is there isn't an established reimbursement model. There's not a chronic condition management code for people with elevated cancer risk the way you have it in cardiovascular disease and diabetes.
Hmm.
So I think there's no quality score. Did you find the people who have an elevated risk and get them on the right screening paradigm? The quality payments are linked to, did you give everybody the average screening for the average person, even though everybody's not average? Um, you don't get dinged
Yeah.
if you
There's no
caught the
such thing as
cancer at stage
average.
one. Yeah, and also you don't get penalized if you caught a cancer at stage one that you at stage four or stage three that you should have caught at stage one because you didn't risk stratify the person. I mean, every time somebody gets diagnosed with cancer, late stage or stage two, that had a genetic mutation that could have been screened earlier or had a family history and could have been screened earlier, why don't they get dinged? Like that's a miss. It's just like the 30-day readmission rule, right? When somebody gets discharged
Hmm.
from the hospital and they go back to the hospital and the hospital gets a penalty. Now they're invested in making sure the person doesn't go back to the hospital. So I think it's one part, the delivery model. I'd say the last piece is you don't have a specialist to do this, right? Who
Yeah.
is actually the specialist that's going to implement this? So I think it's one part, it's multidisciplinary. One part, you need a new clinical model to actually implement it. One part, you have to make people care with money. You have to incentivize people to want to do this, either with a carrot or a stick. Um, and so,
So when you hear the word prevention, like I know what you think of, what do you think the public thinks of? Not someone who knows the amount that you know in terms of the in-depth of this. What do you think the first thing is that comes to their mind when they hear the word prevention?
let me give each leg of the continuum for the average person. I think on one end, I could imagine someone saying, you can't do anything to prevent or reduce your risk of cancer. Cancer just happens to you. I think there's probably still some of that belief, maybe
Yeah.
except for smoking. I think people have done a pretty good job with smoking. Um, and then sort of the other piece would be my lifestyle. Like I think people are learning more about the lifestyle, maybe not the
Hmm.
specific details about what to do and why they should do it, but like some understanding that basic lifestyle behaviors, exercise, food, processed foods, red meat, sunscreen, like all of that. They just
Right.
don't know the details. They don't know why they should really care for cancer and how cancer really develops. And they don't know what is the benchmark for good.
Mm.
Like, how do I know I'm doing a good job? What is a good amount of fruits and vegetables to eat every day? What is a good amount of exercise to do every week that's going to be linked to cancer? Like, what is that number? Is my guess. I doubt people know about the role of vitamin D in protecting you from cancer. I doubt people know about the role of low dose aspirin in colorectal cancer. I doubt people understand why their hepatitis B vaccine and their HPV vaccine are important for liver cancer, even if it's, a lower risk, or cervical cancer. Um, so I think there's probably some baseline knowledge around lifestyle and even some baseline knowledge around family history,
Hmm.
and how that might, but like it's fuzzy. It's not sort of crystallized with concrete steps and a rationale for how these activities connect to your own outcome.
When you talk about, you mentioned that, you made so many good points there. When you mentioned like the prevention, the way you illustrated it, the word that kind of continued to come up to me was clarity. And like a patient wants clarity. And someone who's in I'll just say a state where they want to have clarity on their future. And there's a lot that's being spoken about now in terms of longevity medicine and et cetera. And that clarity, it has a cost. How do you factor that in terms of the population that you want to serve? You want it to be preventative, and yet there is an effort, an energy expenditure that someone needs to put forth to be able to actually go down this path. How do you sort of see those two things working together, and where can you see this actually working even more with the masses, as you mentioned, around like quality and measuring and making sure that we intervene earlier, not later, and penalties. I mean, there's so many factors here, but
Yeah,
yeah,
no,
start there.
no, it's like it's a great question. How do we make comprehensive cancer prevention and detection standard of care? Like that's really the question. Standard of care meaning it's accessible to the masses. So, I mean, with Previvor Edge, we took the difficult steps of getting a network with insurance. So it is accessible from a financial perspective to people through their commercial insurance, which lowers the barrier. I think the second piece is there are people who are going to care and be invested and want to take steps, and there are people who are not. And so we have to
Mm,
start with the people who want to be activated and are looking um, for the clinical expertise, both to help them understand what their current state is, what they should do, and help them implement it, which is what I call the last mile. There's one
right.
thing about like handing someone information and then disclaiming that the information is clinically useful because you don't want the malpractice liability. So there's like companies who do that. Then there's the I am going to give you a clinical plan and I'm going to stand behind the plan, but then I'm going to say goodbye. And then there's the third piece, which is I am responsible for you. I am
Yeah.
here to help you understand your risk. I'm here to build the plan with you, and I'm here to help you implement the plan. And if you need things outside of what you would get from your average primary care or even concierge medical provider, you need specialized a cancer risk management plan, like we're your subspecialist who sits alongside your care team, just the way an endocrinologist or a cardiologist does. Um,
Mm,
and this is a new paradigm. It just doesn't exist. And so I think we have to start creating a movement around here. We need to change, how people think about cancer, and that cancer is very different if you catch it early versus late. That cancer, lifestyle contributes at the level of 40% to cancer. It is like relevant and important because it is a disease of your genetics. And it's all about the rate of mutation and the ability of your immune system to protect yourself from cells that are growing out of control because of mutations.
right.
Um, and yeah, so I think there are people who are looking for this kind of thing. Mothers like myself, I would consider myself in a good demographic. 36% of Americans with a first degree relative who has had cancer, where we know family history has the potential to put you at an elevated risk, or the 70% of Americans who have a clinical risk factor or lifestyle risk factor.
Mm.
And so, but I think um, we need people to understand there are steps they can take, and we need to make it much easier for them to take the steps.
What about there are patients that are out there that are just they think, well, I'd rather just not know. What do you say to that strata, that group of patients?
Yeah, I mean, I think we have to try to understand what the fear is. And different people are scared of different things.
Hmm.
And how the information should actually be fear reducing because there are things you can do. We are not in the business of talking about elevated risk without any action because that is just fear inducing. So, for example, we had one patient come through who, had a significant family history, really needed genetic testing, had put it off for years because she didn't want to know the results. She was scared.
Right, right.
And the reason she was willing to take the next step with us is she felt, well, there was a clinical team who, no matter what the outcome was of the test, was going to have a plan in place for her. And so
Mm.
she felt because she could act on the information, it reduced the fear. But there's definitely going to be people who are scared. And the question is, well, what first step can you take?
Yeah.
And
How
what
much
is
of what you have to do is education, though, to educate and to prime the patient, the population around this? Is that a heavy lift? Or
yeah,
do you see that people are
no.
yearning for this?
No, I think we definitely have to do some baseline education. And
Okay.
we actually do that as part of our clinical program. I think people don't understand the building blocks of cancer risk and why you actually need to go pretty broad and
Mm.
deep in order to come up
Hmm.
with an answer that's actually clinically relevant for them. And so I think, yeah, our job is hard because there is this baseline education gap. There is this like new clinical model to go and visit. And people, it's not like you're signing up to go see an endocrinologist where you're walking in with like, hi, I'm tired. Give me some, let me do my
Yeah.
blood. This is like, I don't want to die from cancer. Like, I want to know that I'm doing everything I can to prevent and detect my cancer. And they need to understand the building blocks. They need to understand the strategies. They need to understand that for cancers, they have elevated risk, what symptoms. So we counsel
Mhm.
people on how to watch for specific symptoms because that's important and not, so, another doctor might say, no, 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 there's no way it could be this. For somebody with elevated risk, we're going to like go investigate that. Um, but long story short, yes, there's baseline education. I think people's knowledge is getting um, it is improving. I think a little bit because of the longevity movement and this desire to invest in your health
Yeah.
and this belief that if you do things today that reduce your inflammation, that your metabolic health is good, that your immune system is in good shape, you are going to prime yourself to
Mm.
not have cancer. But what they don't know is like you could do all that and you can have a strong family history and that's out of your control. Or you have a genetic mutation and that's out of your control. So you have to sort of marry, or you never got vaccinated and you're missing something that you could do to prevent cancer. So there's a bunch of stuff that falls out of traditional longevity. And, it's the 80-20, right? Longevity, talks about this maybe 20%, but like really you just need to do the 80%. Like people don't get the 80% right. The exercise, the red meat, the
Yeah.
smoking, the alcohol, like those are the things that are moving the needle, you know, unless you're like a high sports, performer, it's like the creatine is not the 80%. That's like
Mm.
maybe the last 10%.
Yeah. 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 I'm curious. I want to switch gears for a second because as a high capacity entrepreneurs that we've interviewed, and like it's stressful. I'm curious for you and the mission that you're going after. Like it's a big mission. Do you sometimes feel the weight of that? Have there ever been moments where you're like, shit, like this is really hard? What kind of pulls you back in to keep trudging forward?
Yeah. Every
Because
day.
like it's still early. Like it's still early,
Yeah,
like you're
every
still in
day.
early
No,
days.
it's very hard. It's very, very hard. Um, and I every day it's hard. The things that keep me going are actually like speaking to people who are very credible, very senior in the industry across academic cancer centers, diagnostic companies, who say, like, either I told my company we should build this, like, that's always a good one, or we really, really need to move further upstream. Everybody knows that. It's just really hard.
Yeah.
You have to figure out how to get to the right patients. Um, and then on the patient side, I get sort of like random outreach from people or colleagues I hadn't spoken with in over a decade saying, hey, my wife is going through something like this right now. What you're building is so important. Let me know if I can do anything to help out of the blue. So I think there's sort of like, and then maybe the last piece is, you know, just in my social circles, just recognizing that people aren't getting the care. Like, how many of my female friends don't know what their risk score is for breast cancer and have never heard of it? Like why?
Mm,
So
mm.
it's a combination of like continual conviction of the problem, um, continual conviction that this is an important gap to close, um, that the approach that we're taking, clinically relevant, methodical, multidisciplinary, um, playing within healthcare proper, even though it takes a little longer, is like a solid foundation, um, and is more likely to be broad-based clinically adopted. Um, and that there's a health economics outcome story to this. Like there's a cost story to this, there's an outcome story to this. So it's just hard to build.
How far can you actually peer into the future, knowing that like every day is hard? How far do you look as a founder?
Um, I always have to think about what is the business going to be in a year and what are the
Mm,
major on 2 years or 3 years and like what are the major milestones that are going to get us there. I mean, I want Previvor Edge to be the place to go to manage cancer risk. I want to be the digital home to integrate all the different screenings you're doing, your clinical. I want to be the distributor of both standard of care interventions as well as
right.
emerging diagnostics. Not everybody is going to be able to go to Dana-Farber's early detection clinic. Not
Yeah.
everybody is going to go to the Mayo Clinic. So where are they going to go? Where are they going to go? And who is connecting the dots for them? And so I want to make that conversation as easy as possible. I want to make it as easy as possible to identify the patients who are going to derive the greatest impact.
Mm,
I want to help the patients take action on the things they need to do. Um, and then I want to be able to either hand off the patient to the right next step, whether it's a clinician or another digital service or a diagnostic. So much more as an orchestrator, and as the clinical quarterback. Um, and the more people who know what their risk is, the more people who are on the right detection or screening plan, the more people who are going to take one good step on their lifestyle, the more people who know what to look out for in symptoms, the better off we're going to be.
yeah. You mentioned around care orchestration. Oftentimes that tends to be the issues like, hey, we know we need to take the next step, but like, what is the next step? And the fact that you can kind of guide it for them, do it for them, um, that eliminates friction. I'm sort of just curious. I mean, what is something that you like refuse to compromise on? Even if like the world's like pushing back on you and your team's pushing back on you, what's something that is like, nope, not compromising here. What is that?
Clinical rigor, like the information, the guidance. That's why we have this tumorless board. If a patient comes
Hmm.
in and they don't fit clearly into the guidelines, but we know something's up, we go when we bring it to our expert advisory board, we talk about the patient, we put an action plan in place, we make a determination about risk, and then we put it into our, logic engine. Like
Mm,
I want us, like we are responsible for the care. And I would rather, you know, do what we can to get people the most information possible if there's the
yeah.
potential the information is going to be valuable to them. Um, because I don't want to miss something. That's the other thing. I don't want, you know, I don't want to miss something.
What's your superpower?
I don't know. Connecting the dots, I would say. Like I'm
Yeah.
pretty good at um remembering a lot of disparate things from all different types of industries, conversations, and then coming up with, a novel, commercially valuable insight, and then working with the team to get it done. But sort of like connecting the dots, I would say.
Yeah, I'd say having numerous conversations with you, that's definitely your superpower. Like you're pulling all these different things together and you're using your logic, your reasoning. But you're doing it there in real time. Like it's pretty cool to see that.
Yeah, it's
Where
an Achilles heel. It's an Achilles heel.
it's a blessing and a curse, right? Yeah. Before I forget, where can people go to, find you, find a team, learn more? Like if I'm a patient and let's just say I have an interest in doing this, like walk me through what that process is like and yeah, just take me through.
Yeah, perfect. So we're seeing patients in New York, New Jersey, and Connecticut. You can schedule an appointment directly on our website. Go to www.previvoredge.com, hit schedule my visit. We're going to ask you a few questions. You have the option of using your insurance. We're a network with Aetna, Cigna, United, and the Blues, or some combination thereof in the three different states. You could also go through cash pay. Um, and then you'll schedule your appointment. We'll ask you some questions. So we'll scan you. We have a Previvor health assessment that is specifically relevant to informing your cancer risk. And then you'll meet your clinical team in your onboarding visit. That first visit is where we make sure we have all the right inputs for your cancer risk. And we order genetic testing. If you're interested, if you meet criteria, we'll have that conversation. And if you haven't had blood work in the last 12 months, we order that as well for you because we need that to inform our discussion. And then following that visit, you'll have one more visit, the care plan visit. And that's where we will go through your cancer risk profile. We will talk about whether you have cancers, whether any cancers have an elevated risk for you, why. We'll talk about
Mm.
what we're going to do about it. We're going to go through your lifestyle. What are the things that you're doing today that are actually protecting you from cancer that you should keep doing? What are the opportunities for you to make some behavior changes that will reduce your risk? And we'll explain
Right.
the rationale behind them. Um, and, if there is something that is family related, we'll talk about the implications for your family members, both future and current. And we put together your action plan. Like, what are the things we're going to do over the next 12 months? Um, and we, of course, talk about things like multi-cancer detection tests and full body MRIs and the utility and the evidence. And we will support you in accessing both of these and are responsible for following up on all the findings.
What about education to the families? So let's just say I'm a patient and I want, my wife, my kids to be just understanding of this. How does how does that play into the mix?
Yeah, so I think, I mean, if it's just you and your spouse, if it's just your spouse, I mean, we have
Yeah.
education material, but your spouse can just go through the program because
Hmm.
um, their risk profile is going to be fundamentally different. You're not genetically
Yeah,
related.
that's right. That's right.
Um, But if it turns out you have a family history or you have a genetic risk, we help you explain that to your family member. And if your family member is interested, they should come schedule an appointment and we can help follow up with them too. And so we just make it really easy for you to explain this and to activate family members you think would benefit from that similar investigation.
All right. I want to do a little quick fire here, just to just keep this fun, and then we'll wrap up. So, when you have doubts, when they show up, what do you tell yourself?
Um, I do two things. One is I try to focus on like, okay, where have we gotten to so far? Like I remind myself of sort of where we were a year ago, because it's hard, a month ago in startup world or even a week ago. I remind myself like, what is the core question we're trying to answer right now? I try to
Yeah.
sort of focus on what is the most important thing we need to do, not the 7,000 things we need to do. And I try to just focus on the progress against that. Um, and then I just remind myself, like, we actually didn't need to answer this question today. We have more time to answer this question. So I tend to try to narrow the focus of what has to happen and decide what are the actions we're going to take to move it forward. And if I think that we might not have the best ideas or we might be missing something, it's like, who do I call to see if they have any other suggestions that we haven't done, just to make sure that we have the best plan? So
Mm.
very action oriented, like more, baselining expectations. Like this is like exactly where we should be. It's hard, but it's exactly where we should be. And then like, okay, well, what are we going to do about it? What's the plan? And then I try to focus on that.
What about like a tiny habit that you use come hell or high
Oh,
water? You have it every single day. What is that?
yeah, yeah. I mean, we may have talked about it the first time, exercise. I am religious, and my husband knows this. He still married me, but I am religious about exercising first thing in the morning. Um, and so like that is where I get my best ideas. I think it is a huge productivity tool. Um, and then yeah, and then I think that is sort of my and then friends, like certain conversations.
Yeah.
Uh, can't do this without a network of people. And I'm privileged to have a pretty big network of all different types of people. And I know sort of who to pick up the phone to for certain things. And that's really
Hmm.
valuable.
All right, two more. What's like the last thing that made you laugh really hard? Like gut-wrenching laugh.
Oh my God. I don't know. It was I mean, I laugh a lot. It was probably my kids. I walked in late on Monday and I have an almost 6-year-old and a 3-year-old. Boy is six, older one's a boy and a girl. And we have this keyboard and they were playing the funniest like polka music, dancing around in their pajamas. And it was so cute. And then, yeah, I mean, kids,
That's awesome.
yeah, I would say
They
that
do that
happened.
for you.
Yeah.
They do that for you. What about if Previvor Edge had like a theme song? What would the Previvor Edge theme song
Oh
be?
my God. I mean, I'm gonna just embarrass myself. Um, I
It's
don't
your
know.
episode. You could do whatever you want.
I don't know. I mean, this is when I would call my lifeline. My co-founder Sven would be way better at this. Um, I don't know. I kind of feel like the song that's coming to mind, not the song that I would probably go with, but it's Friday afternoon, is like Welcome to the Jungle. Just it's the first thing that came to mind. I said not what we would go with.
Yeah, yeah, yeah,
Sven
yeah.
would be much better at picking it.
Okay, okay. Um, well, obviously, you're always welcome to come back on the show. I appreciate you just being just who you are. I think what stood out to me today, having done take two, is just you're very practical, but you're also rigorously honest in the way you think through things, and just seeing how you're thinking through this problem, the seriousness of it, the weight of it, and yet you're still really graceful about it. And I think whether someone is listening, someone's listening to this, whether you're a clinician or whether you're a founder, executive, or just someone who's either gone through cancer or walking through cancer with someone who's in your family, I think prevention is no longer this abstract idea. It's actually a reality, and we're a lot closer than what we think. So today's conversation actually brought me a lot more hope. So my hope is today that this conversation, if you're listening to this or if you're watching this, that it made you pause for a moment. Maybe it made you think about your health. Maybe it made you think about someone that you care about deeply or someone that you love deeply. Or maybe it just reminded you that it's okay to ask questions that you've been putting aside. So, if you're watching this and you like it, please, would you mind sharing it? And if there's a topic that you want us to explore more of, or maybe there's a speaker that you want us to have come onto the show, I'd like to hear about it because I do look at the comments and take action on them. So again, this platform is about community. It's not just content. So thank you for listening. Michelle, thank you for joining. Until next time, keep building with purpose, and we'll see you on the next episode of the Advancing Healthcare Innovation Show.